Any other exam candidate if you want to answer, what is rapid response team? Nobody. Zishan, just I am giving you a guess. What is early warning score?
So early warning score are the scores which are used to assess to rule out the patient who are critical, so that early intervention could be done, sir. So there are few warning scores such as Muse, and vital signs. So these are, sir, the early warning
So the
scores, sir.
response team, which is originated on the basis of early warning scores, okay, and it's you can
Okay, sir.
say that it is the team which is the one to prevent cardiac arrest, okay.
Okay, sir.
Like, as the name is telling, okay, that it's a early warning. It's a team which
Yes.
will try to prevent
हमें यार
like
लड़ाई मत करो.
any change in blood pressure, any change in heart rate, any change in respiratory rate, any change in conscious level. Okay, the names you can cram, but the basic concept is like you can see in this picture, a change in respiratory rate, saturation. Okay, so and then uh, like this is Muse. So as you were telling, there are pews there and Muse. Okay,
Yes.
and it will initiate the initial resuscitation, and and then they will coordinate for you see, this is NHS. So just a second. Maybe we will say, because I was just finding a text for it. So the basic purpose is who will be there, maybe because they will initiate uh, CRRT. Okay, in some places they call it as CRRT. So any change in respiratory, because number you can identify what is that one. So respiratory rate, oxygen saturation, blood pressure, pulse rate, level of consciousness, or even temperature. Okay, and then they will like now if you want to expand, so you can expand. There is a stroke team. Okay, there is a of course there is a code blue team. There is a acute pain service. So basic concept is the same, that you on the basis of any science, you will initiate a team. Okay, so stroke team is also sort of you can say subdivision, you can say, or so the concept is the same, that they will initiate and then they will refer to the specific specialty. Like I'm giving you one example of stroke team. Okay, so this was just a feeler. Uh, we had discussed concept of various teams in anesthesia before. Okay, so uh, we have a scenario of a 64-year male, diabetic, hypertensive, ischemic heart disease, like peripheral vascular disease, end stage renal disease. And this is a like real time scenario, you can say. And this patient is coming for creation of AV fistula. Okay. So, how will you evaluate this patient? Actually, this you can say that mainly you will consider it as a diabetes and hypertension. And this peripheral vascular disease, ischemic heart disease, and end stage renal disease is the consequence of diabetes and hypertension. Okay. So, yes, Ishan, how will you evaluate this patient for like you are being called to assess this patient for creation of AV fistula?
Sir, I will evaluate the patient on the basis of history, examination, and relevant investigation, and I will rule out the and I would my and I will rule out the severity, and I will rule out the assess the severity of this disease and its complication in the form of microvascular and macrovascular complication. Microvascular complication in the form of uh, nephropathy, TIAs, and macrovascular complication in the form of MI, peripheral vascular disease, is my peripheral vascular disease, silent MI, and I will rule out all the major risk factors which could lead to the further deterioration of the patient intra-op. Uh, my examination would also be focused on the investigation. My focus will be investigation to rule out any signs of to rule out any danger signs in the form of heart failure, or to rule out in the form of heart failure, and my investigations will also be in the I will also do investigation and to rule out to know the severity of these diseases and its and organ damage, sir. Uh,
Okay, so you are missing something. You have not said anything about end-stage renal disease. And because the patient is coming for AV fistula, so it means the patient will already have got dialysis. Am I right?
yes, sir. That is it. Sir.
So you did not say anything because I know that usually in this scenario you need to tell all these things, but try to tell the thing which is the most important. Okay. So
Yes,
just you got my point, sir, because this the main scenario is for AV fistula. Okay.
yes, sir.
So the more important thing will be that whether like what is the current status of the patient, whether the dialysis, if the dialysis has been initiated, how many days dialysis have gone, okay, and like you will be looking at the line related problems, okay, and any because whenever there is dialysis, even done or not done, electrolyte imbalance can be there, okay,
Yes, sir.
and this patient will have Quentin, for example, the dialysis catheter. So you can just highlight this main important point, which should not you should not forget. Okay, so what in the conduct of anesthesia, what are important points? Anyone else want to speak out? Any other exam candidate or only Zishan? Sajid, you are also exam candidate. Alisha, you want to speak out?
Yes, sir. Other than that, specifically, if we are considering the type or mode of anesthesia, on that behalf, we can evaluate, for example, uh, whether if we want to do the regional anesthesia or peripheral nerve block, for that basis,
Yes.
we can
So the options are
ask the
local infiltration by the surgeon and MAC, monitored anesthesia care. This is one option. The other option will be GA. The other option will be block. So which block you would like to prefer?
sir, axillary brachial plexus block.
Why auxiliary?
We can do supraclavicular also, but XD because it is relatively safe and we don't want specifically upper to anesthetize. I think.
Okay, if you want to defend auxiliary, what will be the advantages of auxiliary?
Sir, less complication related to
What do you
lungs,
mean by
pneumothorax,
complication? Because complication may be vascular damage, complication may be nerve injury, complication may be failure. What do you mean by complication?
less chances of pneumothorax.
Okay, less chances of pneumothorax. What else? Just tell me one thing, in awake patient, which is easy, axillary or supraclavicular?
Supraclavicular.
Why?
I think that we don't have to specific. We have don't have to form specific position. In X-ray, we have to abduct the arm, and
More needle
maybe
handling.
I'm wrong.
Okay,
Yes.
more needle handling. You have to go in one place. If you are giving blind technique or you are giving nerve stimulator technique or something else, that's something else. But otherwise, you have to cover the, like this is artery, you have to move the needle more. Okay. And this is a uncomfortable position in this age group. Is there anything else which can be there? Maybe shoulder frozen, frozen shoulder.
Yes.
Okay. So that is another thing. So in awake patient, it's relatively difficult. And then, for example, is it important to know the location of the fistula?
Mm. Yeah, yes, sir. Mostly, the antecubital foramen is the place.
So the like the take home message is that please in your discussion always say that you have to identify, like when I asked about the location, you should be saying I will discuss with the surgeon. So never forget in the viva the word discussion with the surgeon. I know that we don't have very good relationship with the surgeons, and we don't want to actually don't want to see each other faces, but we are like mother-in-law and daughter-in-law, so we cannot leave each other. Okay, so you have to discuss with the surgeon what is their plan. Like today, I did a case and in which actually they booked the patient for AV fistula, and of course the patient came as a day case. Okay, it was not an admitted, and I found to have a bypass. They have to do axillary subclavian bypass. They have to do because there was big two babies over there, thrombos. Okay, so discussion with the surgeon in the viva, never forget to mention this point because this point will help you if you make your habit. And because usually in our setup we are not ever discussing the patient, so we don't mention this point. So always discuss. Maybe they are doing in the elbow. Maybe they are doing in the wrist. Okay, so you should be knowing where they are making the fistula. And if, for example, there are some other considerations because musculocutaneous nerve will be spared. We need to block in axillary block musculocutaneous nerve separately. Okay, and then and also we have to give a ring to give the intercostobrachial nerve, which is uh, which is you will not be able to cover it in axillary block. Okay, so these things you should be, whenever you are telling, you are committing something, you have to tell the other whereabouts. Of course, in supraclavicular, the advantage is that you can give even a single point, you can give and it can spread. The problem will be that supraclavicular will take more time. Okay, so axillary will be quicker because here, if you are here, the penetration, because peripheral now they have generated almost the nerves. Okay, so it's relatively quicker. So you can make a combination of lidocaine with bupicaine. Okay, so it will be, so this is something. And in supraclavicular, there are, of course, there are chances of pneumothorax will be more. And other than pneumothorax, you should mention about hemidemic diaphragm, this phrenic nerve involvement. Yes, Ali, what you want to say?
Yes, sir. We can say infraclavicular also, or it is obsolete nowadays.
It's not obsolete, but it's a dangerous, like it depends on the preference. Okay, but if you are talking about pneumothorax, the it is even more chances more than supraclavicular. If you are talking about coracoid approach, it's something else, but still it's a deeper block. And awake patient, again, you need to go too deep. So in awake patient, it's infraclavicular block is not a very good choice. Okay, so you can say that whatever you are giving, you should know what you are doing. Okay. So supraclavicular, because it's the spinal of the upper limb. So if you ask me, this is the best block. I don't like to give axillary block. If you are confident, you can. The only problem will be the phrenic nerve. So phrenic nerve problem, if the patient is already, you see, that's why it's important to identify if any overload the dialysis has been done or not. A post dialysis patient is feeling okay. Okay. And even you should mention in a dialysis patient, you should mention about hypo as well. Not necessarily there will be hyperkalemia, there may be hypokalemia, there may be hyponatremia, the disequilibrium syndrome, and the even patient can be low in volume. And then another important thing, remember one thing, that whenever you are telling, you should be telling how much is the GFR. And some there are some patients who are oliguric, okay, but not totally anuric. So if the patients are making some urine, actually this is a safety for you. So make a habit, even this practically it's very important, that you can tell, you can ask that whether the patient is making some urine or no. Okay. Because there are some patients, they make fistula. Even another category will be, even some people AV fistula will be created even before a dialysis. Okay, you got my point, Ali?
Yes, sir. Yes, sir.
Because
Thank
some
you.
people, they know that the patient is going in failure towards failure, so they will electively they will create a AV fistula and they will start dialysis straight away on because dialysis through the line is in sort of emergency. Okay. So next time if someone is, and actually this question is not written in a very nice way in majority of books. So you have to be very careful about answering such questions. So in this patient, the main pathology is diabetes or hypertension leading to the nephropathy, the all the disease because of this nephropathy. So you should be knowing that what is the sequence of event. There is albuminuria, there is corticomedullary differentiation is finished, and then leading to is the CKD, and then it is according to the GFR classification, gradually patient is going, and then all the concerns related to any patient in CRF, hypertension, like the metabolic problems, the arrhythmias. Uh, so you can just chalk out what. By the way, Zishan, would you like to tell what are systemic effects of renal failure?
Yes, sir. End-stage renal disease is basically a systemic disease, so it has a multisystemic involvement in the CVS in the form of arrhythmias, cardiomyopathies, fluid overload, it can cause pulmonary edema and accelerated atherosclerosis. Then in the respiratory, it can, as I said, it can cause pulmonary edema and signs and fluid overload, sir. And then in hematological, it can cause anemia of chronic disease. In neurological, can cause increased chances of stroke, neuropathies, uremia, and in gastrointestinal system, it can cause gastroparesis. There is increased chances of aspiration and electrolyte imbalance. In electrolytes, it can cause, as you said, it can cause electrolyte imbalance in the form of hypokalemia, hyperkalemia, potassium and phosphate imbalance. And then drugs, our drug handlings, alteration in our drug metabolism, and difficulty in the fluid management, and then the concern related to the dialysis that the patient is on. So dialysis can also have multisystemic effects.
Okay, so you should be knowing how to like in a nice way. So you see, that's what I was telling you about this, um, because there will be one classification which will be acute renal failure, and one classification which according to the chronic renal failure. Okay, so this is GFR classification. And another thing which I did not speak out is about peritoneal dialysis, because some people, patients, may be on peritoneal dialysis. Just a second, actually. Mhm. Just a second. Just a second. Okay. So, because you will prepare for so many cases, but this is a case which is a little challenging. If you have not prepared it, it can create problem for you. Mm, see, that's what I was discussing. So, yes, and what is the advantage of giving regional anesthesia? Is there any advantage because they can do it in local infiltration? If the patient is cooperative, you can just have. So, is there any advantage with reference to AV fistula creation, the use of this regional anesthesia?
Sir, just like our spinal anesthesia, vasodilation might help the surgeon to anastomose.
Actually, it is there are some studies that it is better for the outcome of the fistula. Okay, so a
Okay,
successful
okay.
fistula. So this is one of, you see, regional anesthesia can increase vein diameter and higher vessel flow rates, both of which are predictors for successful fistula formation. Okay, so this is another important point you can. mm, Okay, so with reference to renal, you should be knowing what are various um, causes of renal failure, chronic renal disease.
Sorry, sir, can you please repeat the question?
Reasons, etiology of renal failure.
So it can be classified as a pre-renal causes, pre-renal, intra-renal, and post-renal. As far as
Okay.
pre-renal causes are concerned, it might be due to hypovolemia, hypovolemic, hemorrhagic shock. Um, Most likely, these are the main causes. Intrarenal, there are a lot of causes: drug-related causes, pathology-related causes, autoimmune causes, which can cause nephrotic syndrome, and many other causes. And post-operative, most likely there is obstructive causes leading to, for example, such as stones, obstructive uropathy, ureter stenosis, BPH, bladder. All these can cause the post-obstructive renopathy.
Yes, so you should just be knowing the common causes they can ask you, and then as it's mentioned in this chart, diabetes, hypertension, glomerulonephritis, polycystic kidneys, pyelonephritis, and idiopathic. Okay, and okay, what are the common drugs which can cause renal failure? Yes.
So common cause which can cause, say, are the chemotherapeutic medications, medications. Sir, those are known for, and then antiarrhythmic in amidrone, it can cause, it can cause renal, and ACE inhibitors and ARBs, sir, uh, uh, they're also known to cause renal.
ACE
And other
inhibitors,
than that,
ARB.
sir,
Okay, in perioperative period.
Sir, NSAIDs.
NSAIDs.
Okay, so you have talked about chemotherapeutic agent. You have missed the most common thing. Okay, in if you as an anesthetist, one an NSAID, another thing which you will encounter as an anesthetist. What's that?
Sir, chronic opioids, sir.
No, no, no. Opioids does not do anything. What about contrast?
Yes, sir. Contrast induced.
Okay, so the contrast induced, because if patient, there are certain risk factors for the development of renal failure. Okay, so we can like classify into acute or chronic. So chronic will be some disease which are there, or you can say what you identify as patients at renal risk. Okay, so diabetes is top notch. Hypertension is another cause, or any other this chronic causes. But Acutely, it can precipitate because of a lot of anesthetic factors. So one of them is if you have already patient with the renal impairment and you give hypotensive anesthesia for a long time, and then the patient have hypovolemia, a lot of bleeding, and then you use a lot of NSAIDs. So, and then you used this contrast. So all these factors can precipitate uh, some other factors, like, of course, now it's not uh, used worldwide. It's already almost obsolete in majority part of the world. But this, for example, enflurane was related, and then if sevoflurane in low flow anesthesia, uh, clinically not much in humans, it's not considered as a big factor. Then, uh, is it something related to trauma can cause renal failure?
Yes, sir.
Rhabdomyolysis, rhabdomyolysis,
Hypovolemia and
Rhabdomyolysis,
rhabdomyolysis.
hypovolemia, hypoperfusion leading to renal failure, and the other will be in crush injuries. Crush injuries, rhabdomyolysis, myoglobinuria, and another another cause of perioperative renal injury, other than the, of course, the like hypoperfusion and hypotension and hypovolemia. Uh, what about prolonged use of tourniquet?
Yes, sir.
Prolonged use.
Prolonged use of tourniquets can also cause muscle damage and increase
So
the hypoxic mediators, which can damage the injury.
yes. So actually, there was another. I'm not finding it right. So this is about this contrast-induced kidney injury. You can, because it's least likely to be asked in too much details. But if it is contrast mediated, what medication or what are the preventions for prevention of contrast-induced acute kidney injury? Good perfusion, preoperative screening, that preoperative creatinine, if it is high, they will try to avoid contrast, or if it is mandatory, then you can use N-acetylcysteine, good volume status. So these are the things commonly you can answer in this regard. And
but they also use to use a low concentrated contrast to dilute the contrast.
okay, I don't have any idea, but maybe there are some contrasts which are less toxic than other. Okay. With reference to AKI, you should be knowing about this rifle criteria, this KIDCO. I always forget this name. Usually, the thing is that the increase in creatinine and duration and urine output. These are the three things on the basis of which they label it into the various stages. Whatever classification you take, the basic thing will be, you see, 1.5 to 2 times baseline, and less than 0.5 ml per kg per hour for 6 to 12 hours. So if stage 2, you like, if you forget, you can tell in that way that all these classification based on increase in creatinine with reference to urine output over certain period of time. Okay, so that's how they define this progression, or this AKI. So there are certain other things which are like, as you were telling also, NSAIDs, ACE inhibitors, antibiotics, aminoglycosides, okay, and immunosuppressants, and starch, this sterile, and radio, this contrast, certain surgery, emergency surgery, cardiac surgery, this pump, and then transplant surgery, vascular surgery, intraperitoneal surgery, if duration is very prolonged surgery, especially with hypotensive anesthesia, hypoperfusion. Okay. And what's the difference? Usually we kept the blood pressure at 60. You must have heard that the surgeon will say, I want mean 60. Is it okay? Or we should, why we say this 60? Yes, Zishan.
Sir, they say it should be 20% minus from the baseline and
This
not
is one
more than
concept.
that.
Okay, this is one
Yes, sir.
concept. What about,
Other,
what
sir,
about
others, other one, sir, the brain auto-regulation is between in the 60. So brain auto-regulation is maintained, sir, in between the 60. So that's why the 60 figure is famous. But if the
62,
patient is hypertensive, 60 to
60 to
160, sir.
160? And what about kidneys?
Sir,
Yes,
80 to
Ali,
180.
80 to
80 to
180.
1.
So remember one thing, practically 60 is very dangerous. If 60 is for shorter time, it's okay. If 60 is for prolonged time, it's never safe. Okay. So even when whenever you are conducting hypotensive anesthesia, you should be thinking about it. And at the end of the surgery, at least you should give fluid so that if the kidneys are hypoperfused in that time, you are able to prevent any problem. Okay. So you should be
Yes, sir.
knowing, yes.
In this regard, another thing is that um, rightward shift of autoregulation curves. So, if the patient is closing hypertensive, one should also be vigilant about the map.
Yes, yes. So like that's what sorry, Zishan was telling, that if you have any patient in which you are giving hypotensive anesthesia or you are looking at the blood pressure, so it is always better because the reading which is there in the operation theater is not the actually the accurate reading, because that will be a little higher. The BP cuff, there are so many factors. So it's better to have a look on the ward readings. Okay. So the average of that reading you should consider at baseline. So you should try to be remain in that window of 20 to 25% of that window. Okay. So because that's the concept. Because if the patient is coming in the recovery, so in the holding area and the patient is hypertensive, this may be because of anxiety. Okay. Or after the start of anesthesia, if, or in the operation theater after giving medications you are taking a BP reading, maybe that will be a little lower. So you just have to identify what do you mean by baseline 20 to 25%. And another thing is that if you are keeping hypotension for a smaller period of time, maybe 1 to 2 hours, maybe it will not affect that trigger or damage if you are keeping it for many hours. And if you are giving a lot of injuries, like you keep the patient hypotensive, hypovolemic, and then you give NSAIDs and you also use contrast, and now you will be in trouble. Okay, so or any surgery in which retraction, because this is another factor to reduce the renal blood flow. So these all are the factors which will ultimately affect the renal perfusion and ultimately the problems. Okay, so you should not forget about this chart because that's very important. And another, yes, the use of vasopressors. Maybe it is not written here, but if you are using vasopressors a lot, it's to maintain the blood pressure. Actually, it's not a very nice thing. So you should always try to have the perfusion with the use of volume rather than using very high dose of vasopressors, because it will also cause like ultimately it will damage. So these are few points which you should be knowing. And this is another. You see, this is a mnemonic: acid-base balance, water balance, electrolyte balance, hemostasis, toxin removal, blood pressure control, erythropoietin synthesis, vitamin D. And when if you are thinking about the problem, so you can convert their problems. Metabolic acidosis will be there, volume overload will be there, electrolyte imbalance like hyperkalemia and hypocalcemia, and all the problems related to blood pressure will be high. Erythropoietin problems will be there. So to maintain the hemoglobin, you need to give erythropoietin from outside exogenic. uh, okay, so you can just make it in other way. Mm, So this is the chart which you were telling, Ali, pre-renal and renal and post-renal. Because actually, if you come to the scenarios, there will be few scenarios from the same condition. So you should be knowing what will be the concerns of a patient with renal impairment. This will be another scenario. And if the patient already has developed renal failure and the patient is on dialysis, so dialysis patient concerns, some of them we have told. Another heading you can make line related problems. Okay. And then if their fistula is there, you have to take care of the fistula. There should not be lines, there should not be any BP cuff on that side. Even people say that if you want to take arterial line, it's better not to touch the arms. It is better to take in dorsalis pedis. Okay, like because the upper limb is left for uh, possible fistula creations. Okay, and same is the concern if you are a patient with renal transplant. So like almost the same concerns. The scenario will be a little changed that now you should be knowing the steps of renal transplant. So when they are removing the kidney and after that they need to give immunosuppressant, they need to give mannitol, you need to give a lot of fluid, and then you have to monitor the this urine output. Another scenario just strike my mind that is there any concern, Zishan, in a patient who has a transplanted kidney coming for any surgery or any transplanted organ as a whole,
Yes, sir,
especially
there will be
renal
concerns.
transplanted?
Yes, sir,
Yes.
the patient are on immunosuppressive and
This is
corticosteroid
one thing.
steroids, sir.
Again, you have to avoid the renal toxic medications. Okay. Then
Yes.
another important point is that the transplanted kidney is placed where?
Sir, it is placed in the sir, I think in the dorsal, more dorsally, sir.
No, no, it's in the pelvis. It's more so any injury and any like you have to take care about this thing as well because kidney transplanted kidney will be in the abdomen, like you can say pelvis,
Oh,
pelvic area. Okay, so
okay.
they have to avoid any possible trauma to the kidney. Okay, so this is
Okay.
so care of the fistula, care of the kidney, again this immunosuppression. So renal failure patient they can ask you in various scenarios. Okay. Uh, yes. So there will be certain more findings in detail. You can have what investigations they can because this case can come in the long case as well. Okay, so in which you need to evaluate all these things and remember one thing: whenever there is kidney problem, heart will be involved. Hypertension can cause renal failure, and renal failure patient will have hypertension. So these it also will develop hypertension. There will be heart failure. There will be arrhythmias. So all the things will be together. So you have to evaluate uh, all the things. And if they want to evaluate the severity of renal failure, so you can tell the answer in the form of urine complete examination with protein urea, albumin urea, and then you have to find the possible etiology and also corticomedullary differentiation uh, to see the extent and also the GFR. And rest of the things will be accordingly. ECG, and then if you find anything or any clinical finding, then you will go for the cardiac investigations. Okay, and like any patient who has who is advanced renal failure, this patient can become you have to think about uremic encephalopathy as well. So all the things related to maybe if there is something like that, even up to CT scan, like you can find some midline shift or cerebral edema or something like that. So that will be gradually. ABGs will be there. Coagulation, in if you want to identify the coagulation status in a renal failure patient, what test is more accurate?
Sir, BT, BT, sir.
BT, or like the answer is that the normal PT INR is not a reliable one. Even platelet count is not a reliable one because there is a problem with platelet function. So one in highly specialized center where availability, platelet function assay is the more accurate test, but clinically you can do bleeding time. Okay, so bleeding time can tell you. So what else? And again, the chest X-ray will you will find some findings in chest X-ray. You will find some finding in ECG, like problems with related to electrolyte imbalance. And you can find in the ECG, and then gradually, as we discussed before as well, that any sign symptoms, then you will go for further cardiac investigation like echo or thallium scan or anything, thing like that. Okay, so. More accurate about like of course ultrasound is the preliminary, but then CT scan may also be did as they have mentioned here. Cardiopulmonary exercise testing only tell at the end. Don't start it with, like, if they are asking how will you evaluate a patient with renal failure. So cardiopulmonary exercise testing, if you had a look on this article and you reproduce it, no, it's not like that. It should only be asked if some, like, there will be only small indications for using this. This AEIOU for dialysis, acidosis, electrolyte imbalance, intoxication. Yes, with reference to dialysis, you should be knowing what is difference between hemofiltration and hemodialysis. You should know. Then what are the indications? We will just have a look on some article of CRRT as well and dialysis. So the concerns, the dialysis versus CRRT. So CRRT will have less hemodynamic sequelae. Dialysis will have more. CRRT can be used over a prolonged period of time, mainly in ICU patient, and a number of time it is used to remove the water more than toxins. So dialysis will be more accurate for this thing. So like these are some things which should be knowing. Uh, Here there was an article on CRRT. I always forget about the mechanism of CRRT. Who will tell? Because there is one hemofiltration. The half-life of memorizing this is very less. So, Zishan, you remember?
Sir, I know the types that there is continuous veno-venous hemofiltration, continuous veno-venous hemodialysis, and then there is these two are most hemodialysis and hemofiltration.
Yes,
One is the diffusion, the hemodialysis is the diffusion, and the other one is the convection or the formation of ultrafiltrate. It's these two are the main differences in
yes.
hemodialysis and
Ali,
hemofiltration.
can you explain in a better way? Do you remember the mechanism? Yes, actually, this one I wanted. See, the hemofiltration. In hemofiltration, blood is pumped through a extracorporeal system. So whenever there is dialysis, there will be use of heparin and extracorporeal circulation. And this is another concern in such patients, that there will be residual effect of heparin. Okay, this is one thing. Semi-permeable membrane, the hydrostatic, this is hemofiltration, hydrostatic pressure that is created on the blood side of the filter drive plasma water across the filter. This process is referred to ultrafiltration. Molecules that are small enough to pass through the membrane are dragged across the membrane with the water by the process of convection. The filter fluid is discarded and a replacement fluid is added in an adjustable fashion according to the desired fluid balance. So this is the basic principle. I don't know what is that. This is some virus. Just a second, please. I think, oh, you see, crazy. You will have to close it. Sorry for the inconvenience. Okay, so I was telling you this thing. So if someone asks you about the basic principle, this is the basic working principle. If you want to, if you want to explain further, that will be something else. So one is hemofiltration and one is hemodialysis. So this is used in mainly in CRRT, this hemofiltration, if I'm not wrong. Okay, and hemodialysis, uh, this involves blood being pumped through an extracorporeal system that can produce a dialyzer. In the dialyzer, blood is separated from a crystallite solution, disalate. Via semi-permeable membrane, solutes move across the membrane along their concentration gradient from one compartment to the other, obeying fixed law of diffusion. For example, bicarbonate moves from the disalate towards the blood because it's less in the blood side, and urea and potassium move from the blood to the disalate. Okay, so this is, when we appear in the exam, these things, and if you don't repeat, you forget. So whatever I teach, extempore is the one which I have read because maybe 9 years ago when I appeared in this Irish fellowship exam. After that, I never studied, by the way. So these things I actually forget. But uh, don't go in too much details. Try to know the concept, which is the basic one. So if they were asking you about the basic principle, yes, there are a lot of uh, types, but the main principle is these two. Okay. Either it is hemofiltration or hemodialysis. Okay, Ali? And then even this question comes in MCQs, that what medications you can make even a bigger list, that what are the dialyzable and what are not dialyzable. Okay. So digoxin, tricyclics, phenytoin, this oral hypoglycemic beta blockers, benzodiazepine, they cannot be removed through RRT. Okay. And it may the medication which lithium, methanol, salicylates, barbiturates, metformin, minoglycosides, this can be dialyzable. Okay, this is a question they can ask you. What are the indication for this renal replacement therapy? So fluid overload, hyperkalemia, acidosis. Okay, and then any encephalopathy, pericarditis. So these are the questions which they will ask you. What is the principle? What is the indications? What are the medication which are dialyzable and non-dialyzable? And these are the like further that intermittent hemodialysis or continuous. So continuous, these are different types. I don't think so. This is our domain, but you should know a little bit about that. And as I mentioned, these two basic principles should not forget. Okay. So actually, we stopped our discussion many days ago and I finished liver. So these are like mainly uh, the topics which you should be knowing. Then further, they can ask you more detail. What are the reasons of anemia in patient with CRF? What is the metabolic problems? Like you should be knowing each and every step about how, like for example, this one, that whenever there's nephron destruction, there is a problem with So you should be knowing how it is this hyperparathyroidism, secondary hyperparathyroidism occurring, phosphate excretion is decreased. So it is like things are related to it. So the vitamin D3 production is decreased, and intestinal absorption will be decreased. So there will be hypocalcemia. So these are all uh, correlated things. So you should be knowing about this thing. Okay. And and then you should be knowing the whole pathway, that how what happens in the skin with the this vitamin D3, what happens in the liver, what happens in the kidneys. So like you should be knowing the role of kidneys, liver, and skin, and how it is affecting. And so you should be knowing about parathyroid hormone effect and vitamin D, because the absorption will be regulated through all this. So you should be knowing about vitamin D, phosphate, and what happens in renal failure. Okay. So the reasons of anemia in uh, so there is bleeding, there is anemia of chronic disease, and related to erythropoietin. Okay, decrease renal parenchymal erythropoietin production. So this is the problem. And then coagulopathy. Uh, one problem will be because of platelet dysfunction, and then problems will be related to this dialysis, heparin related problems. So another important thing which I was just it slipped out of mine. I was telling something. Sorry, I forgot. Yes, the dialysis improves the platelet function. Okay, dialysis improves the platelet function. So this is another thing you should be knowing. So yes, this patient will be also practically if they are asking. So another important thing you should be telling, that they are also considered because of their gastroparesis, they are considered as full stomach. Okay. Mm, so neurological problem and pharmacological. You see, there are pharmacokinetic changes in CRF, hypoalbuminemia, acidosis, increased free drug. So this is when they are asking you, this is a very important point you should be telling, that free drug will be there. So there will be more sensitivity. The doses of benzodiazepine and thiopental should be reduced. Although the pharmacodynamic of propofol are unchanged in CRF, and the sedative metabolites lack sedative activity, changes in volume of distribution and mental state mean that a reduction in induction dose is also appropriate. Okay. The elimination of highly ionized lipid insoluble drugs is partially or completely dependent on renal excretion. So, you should be thinking about, because I'm just trying to practically how uh, to evaluate, in the sense that you should be knowing the clinical relevance. So if you know the clinical relevance, then you will not forget. So if you're talking about, and then you will correlate in all the anesthesia steps. So use benzodiazepines with caution if you are suspecting encephalopathy. Avoid any renal toxic medications if a patient is having renal impairment. Okay. And then they will ask you few questions, that which opioids are better. So remifentanil is always preferable. Fentanyl can be given, but morphine and pethidine, because they have active metabolites. So anything which is active metabolites, so morphine will be a problem. Okay. And you should correlate your knowledge with the with our which are the medications which are dialyzable. So I always forget the chart. You should be knowing, because when you are explaining, so you should always remember this thing, because examiner can ask you at any time this point. So you should be very clear about it. So about role of like intubation, like induction, you should be knowing that swings of blood pressure, because not only the renal failure, the etiology or pathophysiology of renal failure. Okay. So if a patient is diabetic hypertensive, so all the problems in diabetic hypertensive patient, you can tell swings of blood pressure, autonomic neuropathy, sudden collapse at induction. So it's better, if you want to take arterial line, will be an appropriate thing if you want. And as I mentioned to you, that preferably dorsalis pedis. Okay, because it will, but it's not an absolute indication. If you are not comfortable, because you can say that a number of time they have peripheral vascular disease, and they are vasculopaths. So vasculopath, a number of time arterial line taking arterial line and even venous lines are difficult. Okay. So this is another point you can mention. Okay. Among the rest of the anesthesia steps, fluid you have to use with caution. Monitoring, you can tell about monitoring other than standard one, standard two monitoring. You need to have arterial blood pressure or CVP or cardiac output monitor. Okay. Um, like anything which can precipitate. So you can tell about 5 lead ECG and monitoring of urine output, especially if a patient is at renal impairment. Correlate with the steps of anesthesia or various modalities of anesthesia. Regional anesthesia, whenever there is a patient with the renal failure, you have to be careful. Like central nuclear block, always you can say risk versus benefit. So you have to find out. It's not absolutely contraindicated, but you can monitor the platelet functions, or you can, if the patient is on dialysis, again, clinical practice may be vary. I prefer not to use central nuclear block, but it is not absolutely contraindicated. You can use this word that I will do risk versus benefit if there is no coagulopathy and patient is on regular dialysis, patient platelet functions are improved, and you can identify, then you can give. It's not purely contraindicated, but again, you have to say that you have to use with caution. So, for just correlate with the steps of anesthesia with pre-medication, acid prophylaxis, airway management, monitoring, fluid, and then the recovery. Okay. So, Zishan, is it okay? I think that's enough for today. You can you can just have a look on these articles. So, acute renal failure, chronic renal failure, dialysis patient, CRF patient for any other surgery, pathologies in various systems. Okay. And I think that's what you need to know. And they can ask you about the how to identify what are the investigation which can help you in identifying the severity and what test you should be doing if you have a patient with renal failure. Okay. So I think I will stop here. Thanks a lot, all of you, for joining. And actually, today's session is dedicated to Zishan. Because frankly speaking, because I was very lazy to do the class. So Zishan, inshallah, thanks for encouraging me to take the session. Inshallah, we will continue. I will try to take a session tomorrow as well. Okay, bye bye.
Okay. Thank you, sir.